When and where did you start your social work practice?
I started in 1986 in geriatric medicine at the GAU at the Civic Hospital. The model for geriatric rehabilitation was new at the time, coming from Australia and the UK, and brought finally to Ottawa. It was a very exciting time to be in practice.
Mm-hmm. And what was your primary area of practice?
Gerontology, geriatrics, working with seniors, and eventually working with seniors and their caregivers, which became an essential and integral part to senior care.
Mm-hmm. So can you tell me a little bit about how your practice evolved from there?
I started working in the profession because I had, between high school and university, worked in nursing homes and became interested in the elderly and end-of-life issues. I did my undergraduate degree in liberal arts and had an interest again in end-of-life. Then when I stopped to have children, I decided to go back to a profession that would allow me to integrate both my interest in geriatrics and senior care and in quality of life. So I was delighted when a position opened in the Civic Hospital in geriatric medicine, again in this very exciting field where working with the elderly was seen as different than just the general adult population. They had seemed to have special needs and a different medical approach to their quality of life.
Mm-hmm. So what was it like to practice in the years prior to the professionalization of social work practice?
In hospitals, we were very threatened by the fact that we did not have a regulatory body. Other allied health professions did have a regulatory body, and some professions were told not to refer to unregulated therapists because they themselves could lose their license. So it was critical for social work that we have a regulatory body. And when the College of Social Work, OCSW, SSW, was finally established, it was a great relief that we knew that we had finally reached what was the 20th century requirement for professional practice.
So you saw a real impact on your practice before and after?
Absolutely, absolutely.
So is there a social work contribution or accomplishment you are particularly proud of?
I was instrumental in developing a network, the social work advisory in gerontology, that's since become the social work in aging in gerontology. It made more sense to call it that. This was something that brought social workers together who were all in our hospital. Social work was seen to be a little bit of an ivory tower, well funded. We would send patients home and expect the community to pick up all of our recommendations. We didn't know who else was working in the field. We couldn't understand the different perspectives. So having a network where we actually got together and met each other face to face and found out, what exactly do you do? We were able to identify gaps. When we started SWAG in about 1987, we weren't sure if we were going to be research, just education, what it was going to do, but it has evolved as a network of social workers, a safe place for them to talk, a safe place for them to share some of their concerns, a place where we can hone some quick educational opportunities to bring us all up to date about what's going on in the community, and easily organized, easily administered program, because we have a steering committee that meets just once a year, decides what's the programs are going to be, parcels out who's going to do what over the year, and away she blows. As social workers, we're able to manage something that is extremely effective with a minimum of effort. Very proud of all of the social workers that have made SWAG such a successful network, and something that I would like to see established in some of the other areas of social work practice, but it's certainly worked very well in geriatrics and gerontology.
Mm-hmm. Given what you know now, is there anything you would do differently in your career if you could go back in time?
What I found at the time and upon reflection over the years is geriatric medicine, even geriatric social workers, had a certain amount of arrogance. We knew what these elderly people in their 70s, 80s, and 90s should do. We knew what rehab should look like. We knew what their quality of life should be. And we forced a lot of people to meet our goals, sometimes for our statistics, because the program needed to survive. We needed to see people being discharged. We needed to see people staying out of long-term care facilities, and that was important if it matched the goal of the senior. But a lot of the times it didn't match the goal of the seniors. And I remember geriatric teams saying, "Oh my God, I hope when I'm this age that nobody does this to me, that I don't have to be part of this kind of a program where I'm forced to walk up and down the hall and do exercises to build up strength to get home to do what." So I think in retrospect, something now that's happening, like the Dying with Dignity movement, we're listening more to what the goals are of people in their 70s, 80s, and 90s for their quality of life. And it may not be going out and jogging and skiing. It may be more time with their with their grandchildren or with their friends that doesn't necessarily involve a lot of more physical activity. So what is the minimum interventions that we can do for their quality of life that meet their goals and not meet our goals?
Mm-hmm. So what were some of the challenges or barriers you worked to overcome, and who, if anyone, was your ally?
When I was working in hospitals, discharge planning was considered a kind of I can't think of the word. Discharge planning was considered kind of a lowly role for social work, that the real social workers were doing therapist. I always felt, if we're not doing the discharge planning, who better could do this? Because we do look at the person in the situation and their quality of life as part of the discharge plan. So I was very proud to be a discharge planner. But certainly the barriers were often that other allied health professionals wanted a piece of the pie, wanted to do what we were doing until it became too difficult, until they reached some kind of a complexity, and then they throw it over to the social workers saying, "Here, fix this." So because they didn't have the skills to understand what some of the barriers, to be able to project what some of the barriers might be in the discharge plan. So that was certainly something that was difficult. The threat of working with other allied health professionals who, in hospital social work, didn't understand our scope of practice, so continually trying to have to explain what we could do. In terms of a personal barrier, I think this happens in all areas of social work practice. When you work in an area and somehow suddenly your own family becomes part of a system where you used to work and have expertise. So if you're working in oncology and your child has cancer, you're working in depression and mental health, and somebody in your family or you get depressed. And for me, it was working in geriatrics when a loved one had dementia and I became the primary caregiver. I think that was a very difficult barrier that all social workers, probably all mental health professionals, have to face, but was certainly life-changing for me, or professionally changing in my life, about how I've managed the system and how I understood the pain and the complexity of my clients who are trying to manage these systems.
And who did you consider your allies in those situations?
Well, through all my social work career in medicine, my allies were really my social work colleagues, both in the community, through SWAG. And in the hospital, we had excellent program management at the time that really worked to support social workers and all of the other allied health professionals to prevent burnout, to make sure that you're always on the cutting edge of the technology in your own field. So I know that there have been several shifts to disband program management in these large institutions, thinking that it's cheaper to run it by specific medical condition. However, that does break up the support systems that each of the professions have, and particularly for social work, again, who can be a little bit more isolated, a little bit more challenged because of the lack of clarity for scope of practice.
So any words of wisdom you'd like to share with today's social workers?
Only to say for social workers today and for always that we need to be proud of our profession, and I am proud of our profession, but we also need to be humble in our practice. We are not going to learn unless we have the humility to hear the criticisms, to think of what needs to be changed, to be constantly self-monitoring. So that would be my advice. Be humble and be proud.